Good afternoon, everyone. Welcome to the Department of Medicine Grand Rounds. My name is Vin Gupta, and I'm the Chairman of Medicine at the department here. And I will be filling in today for Dr. Jeff Connors, who is out saving lives in the ICU. Welcome to Grand Rounds. We have an excellent speaker today. I'm going to begin with just a few announcements. First, just a reminder that Research Day is coming up on Monday, April 4th. Dr. Cliff Rosen will be here, and I'm going to be talking about his journey from student to mentor, the road well traveled and well enjoyed. We'll also feature many of our own internal talent and faculty, and we'll have a virtual poster session to allow for maximal interaction. So I hope to see many of you there in person at Cruton Hall RC2 on the 4th of April, that is Monday. I also want to remind everyone that use the Q&A option for questions, and there's a CME link in the chat, and you'll also see the link for Research Day in the chat as well if you want to get more information about that as well. I am privileged today to introduce a colleague and friend, Dr. Vin Gupta. Dr. Gupta is a practicing physician and a well-recognized expert that many of you have seen on TV on MSNBC on matters related to COVID-19. He earned his BA from Princeton University, followed by his MD from Columbia University. He then completed his residency in internal medicine at the University of Washington in Seattle, and then a fellowship in pulmonary and critical care medicine at the Brigham and Women's Hospital in Boston, Massachusetts. In 2015, Dr. Gupta earned a Master in International Relations at the University of Cambridge. And in 2017, he went on to complete a Master's in Public Administration at the John F. Kennedy School of Government, also at Harvard. Dr. Gupta has held multiple positions, including serving as Director of Global Health and Diplomacy at the Harvard Global Health Institute, and a consultant for pandemic emergency financing at the World Bank Group. He is, of course, an NBC and MSNBC contributor and medical analyst, and since 2020 has a new role where he serves as the Chief Medical Officer for Amazon Devices, where in his capacity, he oversees the company's efforts in relation to COVID-19 testing, treatment, and emergency responses. He's currently an affiliate assistant professor at the Evans School at the University of Washington, and also an affiliate assistant professor of health science metrics at the Institute of Healthcare Metrics and Evaluation in Seattle, Washington. I could go on and on about Dr. Gupta, but I will tell you that he has won numerous awards and distinctions, including the Rotary International Paul Harris Award in 2021, which is the Rotary's highest distinction given to a member of the community that has made significant contributions to public welfare. Dr. Gupta is also recognized as a 40 under 40 National Leaders in Minority Health and continues to serve as a commissioned officer in the Air Force, where he has been dispatched to numerous hotspots across the country for COVID-19 care. And perhaps most especially and importantly for us, Dr. Gupta was here and we were honored to host him as our keynote speaker for our Faculty Recognition Awards in 2021. I am privileged and proud to welcome my colleague and friend, Dr. Gupta, to the University of Colorado for his talk entitled Post-Pandemic Silver Linings, Opportunities for Improving U.S. Healthcare Delivery. Dr. Gupta, the floor is yours.
Dr. Chopra, thank you for yet again the invitation back. That's a good sign. And really appreciate just your fellowship and friendship and that really kind introduction. I'm excited to talk to all of you today, especially the House staff and the audience, because I think, and I'm going to dive right in with disclosures real quick. And Dr. Chopra just went into my background. I did want to give you a little bit of my own spin on it so you understand why I'm talking to you about what I'm going to be talking to you about. But I think all of you that are entering the workforce, thinking about fellowship, thinking about your next step in medicine, arguably there has been no better time than this post-pandemic phase that we're entering in, even though I'd argue that we're still in the pandemic, but sort of where we are, this is a fascinating time to really begin your career in clinical medicine as a physician scientist, in industry, you name it. And I'll be able to hopefully share some key lessons that I've learned in the last 15 years across both the health communication space, in industry, working for a company like Amazon, and then in the military, deployed all across the states, at least, for emergency response. But these are the opportunities, as at least I've seen them over the last 3 so years, holding or wearing a few different hats. And I was going to dive deeper for the next, say, 35 to 40 minutes into some of these silver linings. At least that's how I'm thinking of them, and ways in which the pandemic hopefully is going to make our healthcare system, the way we deliver care to our patients, better. So clear silver linings. The first theme is going to be moving healthcare to the home. This is kind of lean into at least what I'm seeing in the private sector space, private-public partnerships that are sprucing up between, say, a company like Amazon or Microsoft and what the priorities of the Biden administration are. There's a lot of synergies there that I think there is broad awareness on, and we'll talk about that. How do we deliver better care at home where people want to now consume care because behaviors have changed? And what is that going to mean about you and your clinical practice? I mean, I will say when I was a decade plus ago as an intern, these concepts of virtual telemedicine, getting medications delivered to your doorstep, there was some sense of that. There were some capabilities in that space, but really that they were dwarfed by what we're seeing now, especially the innovation, the policy landscape changes that have occurred over the last 24 months to enable this type of innovation. It's a totally different world now that you're entering, that your patients are experiencing. I'm going to go a little bit into payer strategies. Who's going to pay for all this stuff? We have, I'm wearing an Apple Watch. I, like many of you, I'm sure, utilize a smartphone. A lot of these innovations require some degree of personal tech infrastructure. You have to own some of this expensive equipment to then benefit from some of these service offerings. Who's going to pay for it, especially for those that can't afford an Apple Watch or a smartphone? We'll get into that and what that means for you and what that means for the next 10 to 20 years of healthcare delivery. I'm then going to take a little bit of a pivot and talk about the healthcare workforce crisis. It might seem abrupt, but I promise, at least I think there's reason to it. And so hopefully you will too. And we'd love to brainstorm and troubleshoot, since all of you are going to be on the front lines of dealing with the fact that we're going to lose 40% of docs and 30% of nurses. These are the estimates from the existing workforce by the end of this decade. And all of you are not going to be enough to backfill that. So how do we do more with less? That's going to be at least maybe a brief pivot from some of these silver linings, because I don't think that is a silver lining. And then lastly, communication transformation, something that I'm really passionate about. I'm sure many of you have been thinking about or passionate about yourselves. How do we better communicate in a health crisis? Because I think that is one of the key gaps here. We have not communicated well as an industry, as a healthcare establishment, to people in need throughout this pandemic. I think it's improved over the last 2.5 years. But unlike politics, military, and business, there isn't a lot of crisis communication expertise in healthcare, or at least there wasn't. How do we address that gap? So diving right in, and I promise to try to stay on schedule here. The numbers to me are pretty extraordinary. That prior to the pandemic, I love this statistic because I live and breathe this world, but the statistics to me are extraordinary. That in Medicare, just the number of Medicare recipients who were receiving or engaged in any type of telemedicine offering prior to the pandemic, 12,500. Now it's 24.5 million of 63 million total Medicare beneficiaries engaged in some type of telemedicine offering. I mean, that is extraordinary. The University of Colorado has its own virtual telemedicine offering, as do other integrated healthcare systems like an Intermountain or a Kaiser, every University of Washington. There is telemedicine across every healthcare system. There's private sector industry plays in this space as well. But what are we really touching on here? To meet this demand, to meet this patient desire for convenience, at-home healthcare, we're needing to expand our suite of services. We need Medicare to say, you know what, we're going to reimburse for that. Later on, we're going to talk about payer strategy. It's pretty remarkable that actually prior to the pandemic, there weren't many CPT reimbursement codes for stuff that you did in the home, or a device that you sent to monitor somebody's vitals. That actually was not, in most cases, a reimbursed service prior to the pandemic. Again, in some cases it was, but the number of reimbursement codes, the number of devices, for example, that we can embed in somebody's home to monitor their vital signs, much more optionality now for the provider to say, yeah, you know what, I'm going to do it and you're going to get paid for it. And if there's money, there's incentive to actually provide a service. That's how, unfortunately, we're still fee for service to some degree, although I'd argue this is actually improving quality of care and reducing costs, but we'll get to that in a second. What am I showing you here? Well, this is early on in the pandemic. This is late 2019 into early 2020. What is McKinsey getting at here with this survey? What they're showing is that in the early days of the pandemic, people were willing to explore something like virtual telemedicine, or were willing to at least try it, in ways that back in December of 2019, 27% either tried or were willing to try virtual care. Now, March of 2020, 47%, that number almost doubled. What were people saying they wanted their providers in survey data to actually provide them in those early days of the pandemic? 30% said that they wanted to have providers have the optionality of a video visit. 30% said make a COVID-19 test readily available. These are the top priorities of patients. And 30% said they wanted better information on how to avoid getting sick. Really stuff that we can do in the digital space. I've been, and this is where I'm putting on sort of my biotechnology hat, really immersed in this space of healthcare delivery and technology, and how the two are interfacing and changing the world in which all of us are going to be operating in as clinicians. Whether you're going into the ICU, I still weeknights and weekends still see what brick and mortar ICU care delivery looks like, whether it's in the Air Force or not. And it's amazing to see the stuff that we can send our patients home with, so that they don't have to come back into the acute care setting, or they don't have to come back into the ICU. We can send them home with a molecular-based PCR test, a molecular grade test for COVID-19 that they can use at home. Now they know how to use this test because it's been normed. People's health literacy, their own comprehension of how to do one of these tests at home is much higher than it was 18 months ago, when the concept of testing yourself for COVID or flu at home was foreign. Let's remember that now rapid tests like the Binax Now, or you name it, this is from Thermo Fisher Scientific, this picture I'm showing you. Now we've come to expect that, you can test yourself for COVID-19 at home, and then report that test, and then maybe you can do something with it, like get a treatment. Not even 18 months ago, the FDA did not allow that. Not even Christmas of 2020 did the FDA allow that. We've had remarkable policy change that's enabled this innovation pipeline to actually impact people's lives in a really short time period. And this is why I'm emphasizing this up front now as a silver lining, because I think appropriately a lot of focus here has been in the ways in which the healthcare system, the public health system has failed to respond to this pandemic, how our leaders could have done better. But there's also been a lot of goodness, a lot of silver linings here that are going to improve your ability to care for more patients. And I think help with patient engagement, help keep patients out of hospitals. And this is the start. I can't, I've talked to colleagues, my counterparts at CVS Health, Walgreens, some of the common players in the pharmacy marketplace. Every one of them is thinking about, how do we get from test to treat same day? So I can get Mr. Smith a prescription for Paxlovid, which I'm going to be talking about in just a bit, same day, if he tests positive on a rapid at home. They're expanding their ability to get same day treatment, because everybody's North Star right now is the same. How do we narrow the window between diagnosis and treatment for, at least in the near term, acute illnesses, things that will cause sepsis, that will avoid, how do we actually avoid needing to do the Rivers trial in the ER, or some derivation on the Rivers trial in the ER? How do we avoid progressing down the sepsis continuum and really root out disease as quickly as possible after a diagnosis? There's so much activity happening now across the public sector and the private sector to address this problem. Remote monitoring. Lots of actually at the University of Colorado, you may be aware, you may not be aware, a lot of innovations happening right in your backyard in terms of deploying some really interesting remote monitoring tools that are now getting paid for by third-party payers that can monitor heart rate variability, respiratory rate, oxygen sat over time continuously for your complex cardiopulmonary patient. The big question that we're going to get into a bit, this is just me being shameless and showing you that back when there was no availability of OTC non-prescription tests that some of us were clamoring for it and showing how easy it was to test yourself. So, I've lost shame sharing with you some of those sort of trials and tribulations early on in at least the public health advocacy space. But going back to remote monitoring, before we go into testing, the big question for all these movement of services to the home is, will they actually improve quality of care while also reducing costs? And some payers have said, you know what, we're not going to wait for 10 years for the data. We're just going to cover it because this makes good sense. It's common sense to cover an Apple Watch, or it's common sense to cover a remote monitoring device for the right demographic, because we think that's actually going to help keep that individual out of the hospital. This is nothing new here. Now switching on to the visual in front of you, testing at home. This is now something I'm sure many of you have already consumed, maybe loved ones have consumed. This is the Illume test that I was involved. We did a large scale procurement for the Amazon delivery workforce of the Illume COVID test because it was an easy interface. You could look at an app. The app can teach you how to test yourself if you're not used to testing yourself and sticking something up your nose, and then you know actually how to manipulate the accoutrements and get a positive or a negative test integrated onto a smartphone app. I mean, the user experience piece was a critical part of some of these at-home tests actually getting FDA approval. The science was there, but they were like, well, what's the usability look like? Can people actually do the test properly and mitigate the risk of a false negative was the concern. And really Illume, I thought, knocked it out of the park in terms of an easy user experience. But it all started approximately with many of us saying, you know what, this is easy to do. People now, we're talking about this all the time. People probably have been tested at a drive-through at this point. This is sort of late 2020. They've been tested themselves in a drive-through they've seen how the swab works, goes into your nose. You then put it into something, an extraction buffer, you pipette it onto something else. It might seem complicated, but in reality, it wasn't. And the FDA basically had to take a risk and say, you know what, we're going to approve some of these tests to see whether people can do this properly or not. And through usability studies, they finally did that. So those were the beginnings of what I think has been a really helpful silver lining to this pandemic, taking advantage of this moment in the pandemic, health literacy at an all-time high, to say our patients can do more by themselves. Let's arm them with the tools so that they can do it. Let's remove policy restrictions. This is going to seem like a complete pivot, and it's intended to all make sense in a few slides, but I wanted to take a moment and talk about Paxlovid, and then I'm going to circle back to early test and treat, sort of to button up this first silver lining. I'm on the Paxlovid steering committee for Pfizer, and what they're trying to do is better understand how to communicate on the purpose of Paxlovid, their oral antiviral, which is essentially a protease inhibitor, a combination of protease inhibitors that, as I'm sure many of you know, will basically prevent the subunits, the protein subunits of COVID-19, of SARS-CoV-2 from assembling and forming an actual new virion. If you block a protease inhibitor, basically blocks the construction of new virions in an infected cell at a really basic level. And so they're trying to explain to people, well, a ritonavir boosted protease inhibitor, so Paxlovid, when is this best utilized? How do we disseminate knowledge to providers and to patients on when we should get this in? People should utilize it. Who should utilize it? How quickly should they utilize it after testing positive for COVID or after developing symptoms? We live and breathe this. So I'm sure to all of you, this is going to seem like, gosh, I've already heard it all about this oral antiviral pill. Well, a lot of patients, I'm sure many of your patients are still probably confused or don't know where to get this pill because it's still really difficult based on the zip code that somebody might live in, or based on local or state health policies. Some local state health departments have very restrictive policies and procedures on how to get this medication. Others just need a verbal attestation from a doc to say, you know what, this person meets the EUA criteria for Paxlovid. Well, what is that EUA criteria? Basically, this was the study, the early evaluation of protease inhibition for COVID-19 among high-risk individuals. I always forget what EPIC-HR stands for. It was a phase 2/3 randomized controlled trial that essentially examined giving 5 days worth of Paxlovid, again, versus placebo to those individuals who were high risk and tested positive for COVID. So essentially, within 5 days of testing positive and having symptom onset, giving one trial group access to the medication, the other, of course, placebo. And the idea here was these were the high risk criteria that were utilized, the inclusion criteria, what defined high risk. And I think just to pivot here real quick, I think a lot of people understand their risk, their medical risk now, sitting here in March of 2022 versus in December 2019. They are able to risk stratify themselves in ways in which I don't think maybe we give folks enough credit for. They're able to identify, yes, I am high risk because I'm 65 and older, or I am low risk because I'm not on this chart. I don't have any of these conditions and I'm less than, say, 60 years of age. I'm going to consider myself low risk. That matters. That comprehension matters when we talk about booster rollout. Who needs a third shot? Who needs a fourth shot? This stuff matters. It also matters on who is actually advocating for themselves to get access to Paxlovid. But this was the high risk inclusion criteria. These were the primary secondary outcomes for the Pfizer study. Really, I want to key in on the primary outcome here, which is the proportion of patients with COVID-19 related hospitalization or death from any cause. That was the primary outcome that was studied in EPIC-HR by Pfizer in this randomized control trial of Paxlovid versus placebo. And what do they find in the modified intention to treat analysis? They found a pretty dramatic, statistically significant finding that early Paxlovid within the first 5 days of symptom onset in those with confirmed COVID-19 high risk individuals, that their risk of ending up in the hospital was dramatically reduced versus those in the placebo group. And you see the numbers here in that p-value, pretty significant reduction in the risk of ending up in the hospital if you got Paxlovid and you met the inclusion criteria. Okay, so it's a grand rounds talk, so I had to do a few just I had to mention a slide with an acronym, otherwise, or a study with an acronym. Otherwise, this wouldn't have been an appropriate grand rounds talk. Okay, let's get back to silver linings. So test to treat. Where are we? Narrowing the window between diagnosis of an acute illness and treatment. I argue is the North Star of clinical medicine. I also think brick and mortar clinics, hospital systems struggle with this. It's hard to get somebody to get tested for an acute condition and then on the back end to get them same day treatment. It's a pain. It's not easy. You got to park, you got to go get an appointment, and it's all sorts of stuff. I can't even fathom doing it. We have an infant here. If he were to test positive for, a condition where we needed to get him treatment, it's appointment scheduling, it's driving downtown, it's going to the pharmacy. It is not easy. I posed this question in social media not long ago, so it's not scientific at all. But the question was essentially, what I was trying to get at was, and I've gotten a lot of user just patient, or I guess feedback from people across the country who I don't know, who consider themselves high risk, who constantly message saying, you know what, I'm having a really hard time getting this therapeutic or that therapeutic. And so I threw it out there, just if people just were able to access medication as quickly as possible, knowing what they know about their own medical risk, knowing what they know about COVID, and about who should and should not qualify for something like, say, Paxlovid, versus, no, I want to talk to my PCP first, or maybe have a combination approach, PCP first and quick therapy after that. What would they preference? And I recognize there's all sorts of bias here in a social media poll on Twitter. So don't hold my feet to the fire here. I'm with you to be skeptical, but I think we're looking for signals. We're all learning together, and I would say anecdotally, which is the reason I put this poll on, on the social media platform, I think anecdotally, people understand risk profile. They understand they can follow basic instructions on who should or should not get Paxlovid. And if given a safe mechanism to get therapy, if they test positive, don't meet any of the exclusion criteria for Paxlovid, like a drug-drug interaction, gosh, do we have a standing order for them at a pharmacy? Do we immediately asynchronously ship them the medication because we want to narrow that window between testing positive and treatment? It's an interesting thought exercise at the very least, made even more interesting by the fact that the Biden administration and our colleagues over in the COVID task force at the White House are in parallel working to expand a brick and mortar test to treat initiative. I'm sure many of you have heard about this now, that the president announced at the State of the Union. They're going live with this in pharmacies across the country. Lots of problems in terms of actually making this successful. But this is where we're headed. This is a silver lining here that I don't think we were talking about nearly as much back in December of 2019. I think a lot of barriers exist to making this successful. First of all, let's lead with inequities. If you don't have healthcare insurance, all this goodness is going to feel out of reach. So how do we deal with that? How are we mindful of the fact that innovation is great, convenience is great, but if you don't have access to care, you're sort of left out of all this amazing efficiency that's being introduced to the system. Patient awareness. I can't tell you, one of the reasons I'm always probing and trying to use social media for good is to understand, what are people thinking about? What are they aware of? Where can we heighten awareness? Because so much of public health and individual health is about awareness and behavior. It's not about science. If that wasn't the case, if science guided all individual decision-making, obesity and smoking wouldn't be the leading causes of death across the world. I mean, smoking remains the leading cause of death worldwide by a long shot, and it's been 60 years since the Surgeon General's report. So, it's all still about awareness and behavior. Transportation, we talked about not wanting to park downtown to get access to a script, to an appointment to get tested. I mean, there's a lot we can do there to make this experience more convenient. And provider awareness. I can't tell you how many people say my doc does not know that Evusheld exists, that pre-exposure prophylactic monoclonal antibody for the solid organ transplant community, as an example. Providers don't know some of these therapies exist. So how do we address these barriers? I know this is going to be controversial among some, and gosh, I'm recognizing I'm probably going to go to, for Michelle, probably expand this out to 1250 here, just so you can plan. I'm running behind schedule. Solutions exist. A controversial solution could pharmacists be prescribers for some of these medications, like a near OTC med like Paxlovid or Tamiflu? What about a standing order for the high-risk individuals? If you haven't already, I highly encourage you to look up this article that Dr. Aaron Carroll wrote in the New York Times a few weeks ago about a lot of these issues that I'm raising right now. COVID drugs may work well, but our healthcare system doesn't. He talks about a lot of these issues eloquently. They will impact everybody's career that's entering the workforce in some way, the issues that he raises, because our patients are demanding a better experience. I'm putting my Amazon hat back on, but we're trying, as are many others, we're trying to figure out a way forward to address some of these problems. And one thought here is, and I'm focused on COVID and Paxlovid because I feel like that's a concrete proximal example of something we're trying to get to people's hands quickly for those who qualify. But envision a user experience on an app where they exist in a state that would allow for a fast track prescription of Paxlovid if the individual is screened for and meets criteria 2 through 7, that they have no contraindications, relative or absolute. They're high risk, they tested positive, and they live in a state like, say, Missouri, that doesn't require face-to-face interaction between a provider and a patient, virtually or in person, to render a prescription. It just requires an asynchronous evaluation of data to make sure that that prescription is safe and appropriate for an individual. And the individual just has to say in an app experience, yeah, I tested positive, self-attested to the questions I would otherwise ask them, and boom, within, say, 4 hours, they have a prescription at their door because they tested positive at home. This is what's happening in the near term. this type of experience. So I'm going to shift here, but I just wanted to take a moment to say that I recognize this may make some uncomfortable. I've had conversations with some of my colleagues in the pulmonary community who say, is this too much too soon? Asynchronous fast track prescribing without face-to-face engagement. But I do think that this is where we're headed in some fashion. And of course, we'll all have clinical, they have mild symptoms. They tell me, we've elicited they don't have drug-drug interactions. That may not be enough for you. You may want an O2 set, you may want to look at them physically, but it may be enough for some of your colleagues. And this is actually operating within the bounds of the emergency use authorization as the FDA has written it. So legally, it's above board. From a regulatory standpoint, it's above board. Will this be adopted? I'm going back to that Twitter poll. I think this is what people want. And we're at a moment right now where we can push the envelope here because health literacy is at an all-time high. So even if we thought this might not have been safe pre-pandemic, I think there's a moment here that we should capture. Leverage health literacy at all-time high. Leverage this concept of people risk stratifying themselves with an awareness of their own risk that I don't think the population had writ large pre-pandemic. We've been constantly talking about this concept of risk. And of course, the innovation pipeline, I think, is pretty obvious. It all exists right before our eyes. Will payers be willing to pay for this stuff? I'll try to speed up a bit. Remote monitoring, let's take that as an example. 29, 30 million people use some sort of remote monitoring device, invasive, non-invasive. Usually those with complex cardiopulmonary disease are prescribed this medication or this device right now. Holter monitor as a sort of an obvious example of a remote monitoring device that transmits information to the cloud that a clinician, that data gets integrated into an EHR. You as the clinician can quickly digest it, make clinical decisions. In the next 5 years, this is from Business Insider Intelligence, the expectation here is that absolute number of users of remote monitoring devices will increase by about 2.5 times to 70 million from 30 million. I'm giving you an example here of the innovation that exists proximally. The bio button. It's something that is a remote monitoring device. It's actually deployed. It's been deployed and experimented with across the UC network to some degree. I'm sure some of you may know more about it than I do if you've interfaced with it. But it was given to healthcare workers who got the Pfizer vaccine to monitor their vital signs for early signs of potential side effects based on deviations from a learned baseline on the heart rate, respiratory rate, temperature, oxygen. Basically, this bio button learns an individual's baseline over the first 48 hours. And if there's deviations from that baseline above or below a certain range, preset range for each individual vital sign, a tele-triage nurse gets alerted. And then that ultimately will, that loop gets closed with a clinician or a nurse calling that healthcare worker. This is remote monitoring sort of 2.0. If the Holter monitor is to look for tachyarrhythmias over time, just to see if something's happening intermittently, this sort of continuous remote monitoring is the wave of the future. And why am I bringing this up? There's so many different ways we can think about innovation and willingness to pay, but I'm bringing this up. I don't intend any of you to read this to any significant degree here, but I made this slide intentionally complex because these are the new codes that CMS, Center for Medicare and Medicaid, have put into the new physician fee schedule for 22. You can now, you as a clinician could prescribe a device that's available to you in your healthcare system and then bill for it, especially if you wanted to say respiratory monitoring. You can do that. If you have a device available to you, you can actually get that billed. You can bill it to somebody who might be a Medicare enrollee, and Medicare will pay for it. This didn't exist even 3 months ago, these sets of codes. And again, the point here is that whether it's Medicare or Medicaid, or if it's Cigna, giving you another example of a large private payer that is now offering as a benefit remote monitoring for some of its patients. When there is a willingness to pay, that's when innovation really takes off. And I hate that I'm talking about money and the exchange of dollars here. But if there is a willingness to pay for a service that's new and that's innovative, that will enhance awareness, provider awareness. It's going to be prescribed more. And that's how you're going to move the field forward. I wish it wasn't the case. I wish we could just say, well, gosh, we have data that this improves outcomes. We should do it. But there is actually no clear data. I'm going to skip ahead. There's some data that remote monitoring might be helpful. Continuous remote monitoring for those with, say, COPD. This is from VMJ Open, published a few years ago as a meta-analysis, looking at various types of remote monitoring devices and whether or not they decreased or didn't change the frequency that certain individuals with cardiovascular disease or COPD, the frequency by which they ended up in an acute care setting were hospitalized. And as you can see here, in some cases, in about half of the studies that were, of the 90 studies that were included in this meta-analysis, across the various conditions, there was evidence, not in every, in about half of the studies across these conditions, that remote monitoring did reduce the frequency of these individuals with underlying cardiopulmonary disease from ending up in the hospital. There is great data that I don't have time to go into that shows that remote monitoring does increase patient engagement and awareness. They're more aware of stuff. There's some suggestion that improves quality of life. There's some suggestion that improves patient communication with provider because there's more touch points. There's more stuff to talk about. What I thought was interesting, at least on the patient awareness side, was that devoted health and innovative private Medicare Advantage payers are willing to pay and subsidize fully the cost of an Apple Watch for an individual that's part of the private Medicare Advantage program that's provided by Devoted Health, which is a really cool, innovative payer that's saying, you know what, I don't need years and years of clinical outcomes data showing that the people that use the watch that are high risk are leading better lives and are not ending up in the hospital or saving me money versus those who don't use it. We're going to take a bet, and we're going to in some ways just believe in the conviction that if people are more aware, if they're more attuned to their step count, their heart rate, that they're going to be more mindful of their health, and that's going to improve engagement with their provider. They'll be willing to troubleshoot early if they notice something's off. That's a bet. I can't give you rigorous data that that's actually happening or that will bear itself out over time when this Apple Watch gets studied in greater detail. But it's interesting, and that's where we're headed. Again, if there's an exchange of finances, of money, that is critical, just like policy change is critical to allow a test to be embedded in somebody's home. Reimbursement change is critical to actually enable these services to reach people. You need both. You need the policy and you need the financial change as well to actually realize innovation. This is the random part of the talk, or it might feel random, and I recognize I have about 10 minutes left here. The imbalance of supply and demand across our workforce. Now, I've deployed a few times now in my role as a critical care air transport doc for the Air Force Reserves. This is the inside of a C-130, actually, caring for patients that we were shipping from point A to point B, non-ECMO capable ICU to an ECMO capable ICU. This is our critical care transport team. Consists of an ICU doc, nurse, and respiratory therapist. And one of, most fulfilling parts of my career to date has been being able to do this. I show this to you because it's these C-130s, and we have some C-17s at Joint Base Lewis McChord just south of Seattle. These 6 months prior to these photos being taken were deployed to Bagram. And then we had the evacuation from Afghanistan. And 6 months later, they were moving COVID patients from point A to point B. And I share that experience with you because maybe technology is the answer. Everything that we've been talking about, sort of the first two silver linings to address the fact that we need to deploy our military to to backfill gaps in across our healthcare systems, to move patients from point A to point B, because we don't have enough of that capability in the civilian world. It's extraordinary to me that resources deployed to Afghanistan 6 months prior were then redeployed for COVID response. I mean, that's pretty stunning. And I don't think that's a strategy. That's reactive. We need a proactive strategy here. I'd like to think that some of the silver linings I just mentioned about at-home healthcare delivery, the innovations happening in the payer space, in the policy space, will make all of our lives easier, because we can do more with our time. We can practice at the top of our licenses, and patients will be happy because, you know what, they can asynchronously get a medication like Paxlovid without us actually having to interface with them in a way that's still safe and clinically driven, with evidence-based medicine. I'd argue that that is the only near-term solution that seems like it's actually gaining traction. Some of these other things, like hazard pay for wage workers, my respiratory therapist on my Air Force team was getting hazard pay because when she was in uniform, she was getting hazard pay because she was in military status. But when she went and did her job as a civilian respiratory therapist, no hazard pay. That doesn't make sense. That's leading to some attrition there. We need more residency. There's artificial limits on the number of residency slots that can be filled, and that's congressionally mandated. That should be filled. I think there's a lot of demand amongst medical students to be trained physicians. We need more docs. We need more nurses. We don't have enough nursing school slots. I mean, these are the types of limitations that exist in terms of how many people we have in the pipeline to backfill the expected loss, the 40% of docs we're going to lose, the 30% of nurses by the end of the decade. We're not training enough people. I mean, this is an existential crisis, and short of technology changes that I think will allow the existing workforce to do more with their time while feeling less stressed and less expended. We need a broader solution here. Diversifying FTE, adopting the UK model, more schools that go, or more pathways that go directly from high school to a healthcare vocational type situation, whether it's medical, nursing, respiratory therapy school. We need more of these solutions, not less. But again, I think the only thing I am seeing get traction are the technical innovations and the policy landscape to enable that might hopefully help address this workforce crisis that we're entering in, that we're already experiencing, actually. Okay, I have a few minutes left, and I wanted to close by just touching on something that I think all of us have a stake in, that is personally something that I've been very involved in, but I think it's a work in progress, and this is building trust in the healthcare system. And really, what's the way forward? This is an essay written by Chris Murray, who directs the IHME at the University of Washington, and Tom Boyke, who directs the Global Health Program at the Council on Foreign Relations. And they wrote an op-ed for the Wall Street Journal a few weeks ago that talked about a study that they published that basically highlighted the biggest gap right now in our pandemic response in the US was a lack of trust in institutions. It was not our healthcare capacity, having an excess of it or lack thereof. It was not metrics that measure pandemic preparedness, our style of governance, or income inequality. It was actually countries that had higher levels of trust in their government and in institutions, health-based institutions, did better, had less deaths from COVID than those that had lower levels of trust. That was the key variable driving the heterogeneity that was seen when it came to morbidity and mortality from this pandemic. It's a kind of shocking finding, but maybe not super surprising when we think about what we've experienced here in the United States these last 2+ years. And I argue the best way to build trust is through better communication. This is from publicly available data, but basically everybody, I'm sure this is your lived experience too, and you might be seeing this from your patients, but the reason I've been talking about social media is because this is the dominant form in the ways in which people communicate and consume information now, versus say even 5 or 10 years ago when I was coming up through various training programs. We were not we were still looking at print journals as recently as 2010, 2011. Now everything's really completely moved into the digital space, especially healthcare information. How do we develop best practices for effective communication in the virtual space? That's the grand challenge of your time. I'd like to help all of you, but I think that is going to be one of the near-term challenges for your generation as you enter the next phases of your career. How do you effectively communicate using all the tools available to us now to reach more people, to build trust, so that we don't have a repeat of the last 2.5 years? This might be the most important problem that we will all have to solve here. Healthcare workforce crisis, making sure innovation reaches all people, those are important considerations, problems to solve. Don't get me wrong, but maybe this probably, arguably, is the most difficult issue that we have to face. I like sharing this because I just think it's interesting, and maybe it's a proof point. I posted a picture of lungs. I have it here. It was these lungs. This is from a patient of mine who died from COVID back in August of 2020. These are normal looking lungs. And when I was trying to drive home, why is it that you get vaccinated for COVID-19? It was to prevent your lungs from looking like this, sort of tipping a hat to what we've done so well when it comes to reducing the prevalence of smoking. Obviously, we have a ways to go, but we've really leaned in the smoking cessation efforts on visuals. So I said, well, let's do something similar. Something like that just was highly engaged. It was a tweet that people engaged with. They interacted with it. They understood the message. It was simple, basic, nothing nuanced here. And then at the time, the most commonly cited, the most frequently cited New England Journal of Medicine article on COVID had 4 times less engagement, 1.5 million views, versus just a simple message using visuals on Twitter, almost 5.5 million views. How we're communicating is changing. How people intake health information or all sorts of information is dramatically changing as we speak. And if we don't have a proactive social media strategy, if we don't develop best practices on how to be better communicators as an industry, I think we will not have fully internalized the lessons of this pandemic and actioned on them. I think you probably know what I'm getting at here, so I'll just say this quickly and kind of wrap it up. It's astounded me that to this day, when we're talking about the BA2 variant or Omicron right after Thanksgiving, that there's so much news media focus on does a vaccine against a contagious respiratory virus, does it prevent you from testing positive or experiencing mild symptoms versus averting severe illness? I mean, we have normed prior to this pandemic that you get the flu shot to keep you out of the hospital. And even in that case, it might do it 50% of the time. It's 50% effective in a good year and reducing your risk of ending up in the hospital. But that's the purpose of getting the flu shot. Suddenly we lost the plot when it came to the COVID shots, and we're trying to make this complexity real for people. Oh, well, Sputnik is 73% effective at preventing severe illness, but it's 81% effective at preventing you from testing positive from the Delta variant. It's craziness. It's so complicated. And I think people have lost trust because we have not clearly communicated the basic point here, which is the vaccines keep you out of the hospital. They're really good at that. They're variant agnostic, and they remain really good at it, regardless of whether it's the BA2 variant or Omicron. I don't have enough time to really wrap up those last few slides. So I will wrap it up here, and then Michelle, kick it back to you. There's almost too much to talk about, and I wish we had more time, but there are a lot of silver linings to this pandemic that I really strongly believe will improve the patient experience, will allow us to do more with a smaller workforce, even though I don't think that should avoid us thinking big about solutions to really recruit, train, and retain more healthcare workers across different cadres. But there are meaningful silver linings here if we learn the lessons of the last 2.5 years. And I'd argue really figuring out best ways to communicate to more people effectively is the near-term challenge. I hope we seize this moment to improve on that, but would love to have a discussion if there are questions. Thank you.
Vin, thank you. That was outstanding. I'm actually scribbling notes as we speak because there's so many questions for us to get to. And they're broadly in several categories. There's questions about telehealth, there's questions about trust, there's questions about technology, and there's questions about workforce and pipeline. But maybe I'll start with kind of a common theme across these questions, which is around consumerism in medicine. So someone wrote that we've seen the rise of consumerism in medicine, especially post-COVID. It's clear that we're now thinking more about the patient experience, where patients need care and what care they need. But patients also have choices now and are choosing systems much like they're shopping for various goods. Do you see that as a good thing or a bad thing, and why or why not?
I firmly land in the camp that I think it's ultimately a good thing because it's going to help drive transparency and costs, and that's what we've long needed. We've needed people to understand, just like when we go shopping, we see a bill in real time when we hand over our credit card, what we're paying for, why we're paying for it. There's a volitional aspect there. Like, oh gosh, I'm getting this suite of services. I know what it's going to cost me, and I'm a willing participant in it because I see the value of getting this set of products. I think that there's an imbalance of information right now in the ways in which people consume healthcare. They magically get billed behind the scenes for a set of services that may not seem totally clear to them why they're getting it. Those services often may take a lot of time to actually be provided to them. There's a wait period. And so this consumerism aspect, in my view, is going to force transparency and costs over time, maybe not upfront. And it's also it's because so much of healthcare is driven by, or individual health is driven by behavior. I think if you make healthcare consumption more convenient, especially for conditions where time is of the essence, like COVID treatment, early diagnosis of diabetes, you name it. I mean, I think that ultimately means really good things for brick and mortar healthcare systems and ERs that have to otherwise deal with delayed diagnosis. So I see a lot of upside, but I think the devil's argument or the contrarian argument here would be, well, this might just lead to increased consumption of care without any measurable value. And I think that's a fair point here. Time will tell.
Terrific. There's a whole bunch of questions on telehealth and care outside the hospital. And I guess the first one that I want to highlight is who will end up paying for care outside the hospital? Do you think this is the healthcare systems that will take the charge here? Or do you think this innovation will come from outside of classical healthcare systems, for example, like ours?
I've seen no reason to believe that the existing payer landscape, I mean, whether it's public or private, won't be eager to pick up the cost, because at the end of the day, the value prop here is that all these innovations are going to save them money over time. It's going to mean less filling up the census of a Colorado inpatient health system, or it's just going to ensure that you're not getting surged every winter, and that you're able to manage things with your existing workforce, your existing supply, that we don't have to take heroic measures. So I suspect, I mean, as we've seen, whether it's remote monitoring, time will tell about virtual test to treat. But there are signs here that payers are willing to move away from the dogma that has defined what they have and have not historically been willing to cover. Usually that's 10 years worth of clinical outcomes data to then justify covering a benefit. Now we're seeing that playbook essentially being tossed out in the face of, I think, one, the pandemic and the ways in which it's shaping patient preferences. But I think they're meeting the moment as well, that people want to consume care at home, whether it's delivered by their routine doc or by an innovative service. So I think payers will see an incentive here. The question will be, to what degree will existing healthcare systems view this as complementary and welcome it versus view it as disruptive to bottom lines? And I think that's going to be the big challenge.
That's great. And I think this next question is very much along those lines. So sticking with telehealth, how do you see that fitting in with the current physician, it could worsen shortages. Even in Denver, it can take months to get a new PCP. How do you weigh that in your mind in terms of the calculus?
I think there's going to be near-term pain here for sure. And the problem here is that if people don't have a good experience up front with something that they're dipping their toe into, like virtual telemedicine, they may shut off from it forever and say, you know what, this felt too good to be true. I do think that all these innovations need to focus on building trust, which is why I think virtual test to treat to me is that near-term North Star for all these, whether it's a CVS, whether it's an Amazon, whether it's working in partnership, to say, listen, this service will complement what a brick and mortar healthcare system does so well, which is acute care, obviously preventive medicine across the spectrum, but this can be a nice complement to help them. And this is where we can also build trust, that we can get stuff to people quickly. And that's the logistics heft that sometimes a healthcare system, brick and mortar, may lack. That's where private sector could be really helpful, just last mile healthcare delivery. I'm hoping that that's where private-public partnerships, the private sector really focuses on their efforts on, so that there's trust all around. But to your point, is there enough slack in the system if everybody tries virtual telemedicine tomorrow? No, there isn't. And I think people will have some bad experiences. There's going to be pain points. This is not going to be all rosy up front. And so yes, there's a risk here that this could backfire, absolutely. Which is why I really spent a lot of time focusing on test to treat, because I think that's one of those things where you can maximize people practicing their top of license scope. Like, you don't need a doc necessarily to say yes or no to Tamiflu or Paxlovid. That could be a nurse practitioner. That could be a pharmacist, Vinny, if they have all the right information. And right away, you remove a lot of, well, I call it friction, but you remove a lot of work for the MD that can focus on more top of license practice. But we're not there quite yet.
So let's talk about that trust on the patient side of things. First and foremost, who would be medical legally liable for an adverse event that may happen from a prescription medication distributed via test to treat program if it's not an MD? Would this be similar to an OTC med, for example? How would we think about these in terms of liability if something goes wrong?
Yeah, absolutely. I mean, at the end of the day, there's going to have to be a supervising MD somewhere. And so whether it's in a state like Missouri that allows for ARNPs to practice under the supervision of an MD, there will be an MD that's ultimately liable. So I think the question here is, where can you stretch clinical practice so that the MD is not directly involved in that loop, and there's some degree of maybe oversight. There's accountability, there's oversight, but it's not. It doesn't involve direct engagement, patient to patient. That is so. An MD is never going to be outside the loop there. I think the question here is, to what degree do you create these supervisory accountability mechanisms? And I think there's a lot of models out there. But yeah, I mean, I would also say, I appreciate the question, and I think we have to think about adverse events. How do we mitigate them? How are we rigorous in that intake questionnaire that somebody could click through? I'm on these medications. I am 60 and older. I have mild symptoms, through self-report. I think a lot of this is taking a leap here, that people can go through that experience, that we can trust their responses to what they're putting in there, that it's almost a self-selected crowd that's willing to engage in that type of asynchronous experience in the first place. And that, whereas 2.5 years ago, this might have felt uncomfortable, this is where we all have to take a leap at some point to say, this is that moment. People that will self-select into that service, you don't have to go through that asynchronous experience, but if you want to, you're probably doing it because you feel confident, you know what you're doing. And states will allow for it. But yes, at the end of the day, an MD has to exercise their clinical discretion. Will they be willing to put their license in a supervisory scope or direct scope on the line to enable such a service? I would, because I think that's where we're headed. And I think people self-select into this that know what they're doing, but I recognize that that's a risk, and people have different risk tolerances.
Let's talk about pipelines, since we just have a couple of minutes left, so maybe a couple more questions. One question comes from an individual who says, I'm the faculty educator at the PA program here at CU. Have there been discussions on a national level about supporting PA programs in an effort to increase the supply of healthcare workers with the predicted loss of 40% of the clinical workforce over the next decade? The average PA program is 2 years in length, so they can be turned out much more quickly than MDs. Thoughts on that, Dr. Gupta?
If they haven't, they should be. I can't speak with any expertise on that specifically, but I will actually take that as follow-up because I'm interested in that very question too. Especially, I practice in ICUs where it's all PA driven, with me as the sort of the supervising MD. So that is a gap in my knowledge that I need to remedy. So I will look that up. But if it isn't an area of focus, it should be. So I appreciate that question.
Thanks, Dr. Gupta. So one last question. I think, hopefully there's so many more we can't cover, unfortunately, but I think this one's an important one that I'd love your thoughts on as somebody who's an expert in the field. Is you've talked a lot about the importance of communication and trust and transparency, but can you say a few words about the potential for miscommunication of healthcare information and liability? One could argue that we've made several false steps here with respect to how we communicate, but specifically talking about miscommunication for information and the liability there. Where should that sit? Who should that sit with?
Well, just like our lawyer friends in the law industry can be disbarred. I mean, I guess the way I'll respond to this is those that willingly traffic and propagate misinformation, since I think that's sort of clear to us who's doing that. We've all seen it to some degree, whether it's ivermectin or something in that continuum. And they continue to do it, even though they've been called out on it by the highest officials. Just like our friends in law have pretty clear rules on who can and cannot be delicensed, what accountability looks like, I firmly believe that there needs to be examples set from, especially amongst individuals who've trafficked in this space, that if you do that and you've been warned and you've been cited and you continue to do that, that you risk losing your medical license. And without that type of accountability, people are going to continue to do this with impunity. And so that to me is number one. I do think social media, Twitter and others are taking a more proactive approach to flagging misinformation. It took them some time. It's not perfect, but I think we need to start policing our own so that there is an understanding that there will be serious consequences far beyond just repudiation and the loss of respect from your colleagues, that you will lose your license and there's clear consequences. We aren't there yet, but we should be.
Dr. Gupta, thank you. It's 2 after the hour, and I want to be mindful and respectful of your time. You should know, we've had lots of requests for the recording for this session. So for those of you listening, this will be available in a couple of days at the site in our chat here on URL. Dr. Gupta, thank you as always. Always enlightening, always informative, always entertaining, and importantly, always thought-provoking. And we appreciate your time. Thanks very much.
Oh, thank you, Vineet. Thanks so much for the invitation again. Thank you, everybody. Look forward to staying in touch.
Bye-bye.
Bye.